Now I would like to invite Dr. Pradeep, who's going to talk about Mactal insight and importance of wild field octa. Colonel Pradeep is right now working in Research and Reference Institute, Delhi. He is known for his most magnificent surgeries that he does in RNR.
Good morning, everyone. Thank you for joining us early in the morning. Generally, you expect the hall to be empty, but we are extremely thankful for our audience. So, coming to the point, let me talk about macular telangiectasia type 2. It's a bilateral perifoveal retinal neurodegenerative and vascular disease. So, here we are dealing with a condition which is both neurodegenerative and in its later stages presents with few vascular signs. So the chief pathology is Mueller cell loss, presents in the aged at 5th to 7th decade, and that is where the picture becomes confusing. That one has to differentiate it from age-related macular degeneration, and a large part of this particular disease occurs in diabetic patient, where you have to differentiate it from the diabetic retinopathy changes too. The deep capillary plexus is the one which is mainly affected. Occur in both the inner and outer retinal components, resulting in photoreceptor layer atrophy, RPE clumping, and aberrant neovascular complexes. So there are a lot of differentials to MACTEL2, and I'll come straight to the point that why OCT angiography became so important in macular telangiectasia. Because what we were seeing on OCT were simply few hyperreflective spots on the temporal part of the field, but when we started looking at the OCT angiography images in the deep capillary plexus, we started seeing definitive signs of MACTEL. So this is what a normal octa looks like. One has to appreciate that there is an absolute symmetry both on the superior and the inferior half of the superficial and deep capillary plexus passing through the fovea. And the published evidence on MACTEL tells us that when we are looking at the superficial capillary plexus layer, one sees a lot of dropout changes and few dilatations which are more temporally compared to nasally. But the main changes occur in the deep capillary plexus where you see vascular dilatation and these beautiful telangiectasias. And it has been said that they are concentrated temporally in the superficial capillary plexus only, but when you go to the deep capillary plexus, these changes occur symmetrically around a ring around the fovea. And this is where you can appreciate that the yellow arrows in the upper slide show the superficial capillary plexus changes temporally, while the lower ones show a more circumferential kind of affliction. And as of 2022, we have seen these beautiful images of the late stages. Mind you, these are the late stages of MACTEL, where you find a lot of superficial as well as deep capillary plexus changes as dilatation. Now, coming to few of our cases. This is a case where you see in the OCT, you see a small space on the temporal aspect of the fovea. Now, you may wonder that what this particular space may be, and ophthalmoscopy as of today is not resorted to by most of the specialists, usually in the clinic. Once you go towards the OCT angiography, this is something which if it is available on your console right away, you are able to appreciate on the temporal part in the deep capillary plexus, there is an increased spacing between the vessels. Few of the vessels are dilated, and here becomes a corroborative evidence for you to call it a macular telangiectasia. The important point is that you should be able to see similar changes in the fellow eye. In the fellow eye also, we saw these small two spaces towards both ends of fovea, and when you looked at the octa images, the diagnosis was clinched. Now coming to the late non-proliferative stages, these are the ones where ophthalmoscopically also you start seeing a little bit of clumping of RPE and these kind of outer retinal cavitations. And again, now here you see in the deep capillary plexus in the middle of my slide, on the inferior part of the foveal vascular zone, you are seeing those beautiful dilatations. This is where the diagnosis becomes very simple using an OCT angiography. And coming to the late non-proliferative stages, one can see here that these changes progress with time, and sometimes even when the OCT does not show cavitary changes or RPE defects, you are able to appreciate these kind of vascular dilatation and tortuosities. Lastly, I'll talk about the proliferative stage. So you see this kind of OCT, and you find, I'm extremely sorry, the slides jumping. And you find that the deep capillary plexus shows you classical changes of Mactel, while the outer retina shows you early proliferative changes, which can be seen as these hyperreflective shadows. The Mactel can occur along with an associated active CNVM, as in this case. But not everything which is bulbous is a Mactel. Here we are seeing a classical case of diabetic retinopathy, where this kind of bulbous change occurred simply because of capillary dropout and a reflex angiogenesis that was occurring. Talking about the differential, this is our published work. CSC can occur along with macular telangiectasia. So you saw a patient with 20/60 vision in right eye and 20/40 vision in the left eye. You saw the right angle dipping venules. You saw few PEDs around the fovea. And the OCT tells you a mixed picture that whether, as Dr. Bowen was saying, it's a PCV or it's a CSC. But once you do the OCT angiography, you're clearly able to see that there are no BVNs here. And the changes of Mactel are lying alone. So here we came to a diagnosis of CSC with Mactel in this case. The deep capillary changes were much more prominent. Coming to the second case of a polypoidal choroidal vasculopathy occurring along with Mactel. These were the cases where you saw in the OCT angiography the BVNs. Then there was another case where we saw an acute CSC along with macular telangiectasia. If you look at the OCT, on the left hand side you can see the classical cavitary changes, while on the right hand side you can see a thinning of the fovea. The OCT angiography slides clearly show you that there was a lot of deep capillary plexus dilatations, and they gave you a diagnosis of Mactel. In a case of CDME, you might sometimes get confused when you see this kind of appearance of deep capillary plexus, where the interspersed spaces are increasing, but there are no actual dilatations. Similar feature can occur in a post-RVO macular edema, where again you might see increased hyperreflectance on the OCTA deep capillary plexus images. But try to see that they are not symmetrical along the foveal superior and inferior axis. So this is one hint which tells you that we are not dealing with a case of Mactel. I'll come to my slides on wide field OCTA for the sake of time. So why we require wide field OCTA? It's a non-invasive modality. It can be frequently repeated, and there are no contraindications to it like comorbidities of renal failure, and no dye allergy exists. So it is important to form a diagnosis, especially important in CNVMs, especially the inflammatory CNVMs and CNVMs occurring over choroidal ruptures, where the OCT alone will not be able to guide you towards a hyperreflective layer, which you will presume to be a CNVM. In Mactel 2, there has only been a recent evidence towards the use of wide field OCTA, and it is extremely important in my practice in cases of vaso-occlusive vasculitis. It also helps you in therapeutic decision making, where when you see large CNP areas, you can add on laser and vice versa. This was already spoken by Dr. Amandeep, and it helps you in visual prognostication, where you are able to see the foveal vascular zone health. And if you see capillary dropout areas towards the periphery, you can correlate that well with permanent scotomas you see in the visual field of the patient. And most importantly, it is an amazing educational tool for patients, where you can actually motivate them to go for therapy. This is how a 3 mm scan looks, and this is how a 9 mm scan looks. And you can see non-ischemic CRVO patient here, STBRVO patient here, and this is my favorite, a retinal vasculitis patient where the macula is getting threatened. And these are the patients where we are actually able to make a difference to the patient's life. Once you see this kind of invasion occurring towards the macula, you are immediately able to guide the patient toward either IV methylprednisolone or a pulse IV cyclophosphamide, and able to save the vision of the patient. Thank you so much. Sorry, I had to hurry up with my presentation.
Uh,